Steve Sears from the CDC because we're going to talk about issues related to allergy. So as usual, we are in. Did you start recording? Yes, there we go. There, I think. So if anybody does not want to be on a recorded session, now is the time to stop or to exit. We do offer zero point 0.5 hours of CME as usual. Drop an email, not in the chat, but an email to covidcme.dhhs@maine.gov. We do not have any financial interest to disclose. And as I mentioned, we are really pleased to have Dr. Peggy Penoyer, allergist, immunologist, with lots of experience talking about today the issue of assessing and managing allergy-related issues and related issues of monitoring safety for some of the vaccines that have been out for a while. And then we'll have Steve talk a little bit about the J&J vaccine and the anticipated review of that data. So with that, Peggy, I'm going to pass it to you. And I'll just advance because I'm doing it off of my screen here.
Great. So basically, we are finding that these vaccines are both effective and also safe as they review. The CDC is reviewing the numbers. Again, the risk of a flu vaccine anaphylaxis is about 1.2 per million, and Pfizer is looking like it's only 5 per million. The Moderna is even lower at 2.5 per million in the early evaluation of this. And so these vaccines really are looking like they are causing anaphylaxis on only rare cases. And so it's important to stress that to patients because I think there's heightened awareness of this as all of these questions on our pre-vaccination checklist arise and patients are questioning safety. And again, the big question comes down to questions 3, 4, and 5 that pertain to allergy. And so this is how a patient would come to your attention. And I was going to move on after that. So basically they're asking if you have a polysorbate or PEG allergy. And I think, so Maine Health tried to devise an algorithm to look at polyethylene glycol. In my 30 years in practice, we saw only, I only saw 2 cases of it. It's uncommon. So again, we're not sure that that is the active ingredient, but out of an abundance of caution, the CDC set up early guidelines and urged us to look for polyethylene glycol and also cross-reacting polysorbate. The World Allergy Organization came out and said that polysorbate probably is not that cross-reactive with the higher molecular weight polyethylene glycol, but they're similar. And so again, abundance of caution. They're asking everybody to check into this. If you look, this is Maine Health then devised an algorithm for their medical directors and for their clinic vaccinators to try to figure out and tease out the allergy issues that were going on. And the algorithm looked like a massive spaghetti 2 weeks ago until the CDC came out with a better clarification of what they mean by polyethylene glycol and polysorbate allergy. And so they clarified and said that basically if your patient knows that they have polyethylene glycol allergy based on likely an assessment by an allergist or polysorbate, even less common. It's a hugely popular ingredient in medications and everything. Polysorbate is found in almost everything, numerous vaccines, and most people tolerate this well. It's in a lot of foods. And so again, we think it's going to be safe, but for now we're evaluating it. So if a patient knows they're allergic and answers first, have you had any? So if you go through the history, it's going down into this first one. Obviously, if they don't have anything, they would just go into 15-minute observation. But you shouldn't vaccinate anybody who has had a first dose serious allergic reaction within 4 hours to their vaccine, or has had any hives, any asthma, any other symptoms, and you should refer them to an allergist for evaluation before their second dose is administered. Also, if they know that they're polysorbate or polyethylene glycol allergic. And so that clarification really helped. Moving down the algorithm, Lisa, to the next diamond below, they then asked, do you have any allergy to any IV drugs or insects? To any insects or can't read. Allergen immunotherapy reactions fall into this category. And if they have that, you then want to clarify, was it serious anaphylactic? If it wasn't, again, just 15 minutes of observation. But if they did have anaphylaxis, you just have the patients observe for 30 minutes. So this algorithm sort of helps guide you down into the higher risk categories as you go. And so then next category to the left is the IV antibiotics and IV, let's see, so IV antibiotics and IV narcotics. And also anybody who has idiopathic anaphylaxis, and that would have been diagnosed by an allergist. So, but it's interesting, those people should be observed for 30 minutes. Most IV antibiotics don't have any polysorbate or polyethylene glycol. Same thing with the narcotics. So that keeps you moving down into the next step. So if they have had no reaction to that, you then inquire, have they had a problem with IV contrast? And the IVP dyes, the IV contrast dyes, MRI dyes don't contain polyethylene glycol. There's one notable exception of agents, and these are the ones that are used in ultrasonography and echocardiographic studies. But stress echocardiographs do use Lumison and Definity, these polyethylene glycol containing agents. So if you do get a history of somebody who claims that they have contrast allergy, that they had a problem with an ultrasound or a stress echo or stress testing, it's good to inquire first before moving down. And then those patients would move down still into this precaution where you would then want to weigh the risks versus benefits for this. So again, whether it contains polyethylene glycol with the medications, so we know that a lot of the biologics, a lot of the agents that are now increasingly common do have these agents in them. But if the patient isn't known to have reacted to that specific ingredient in that medication, then you just should discuss with them what the risks are. There are some references listed here, but I'm going to go ahead into the next slide. Lisa, do you think I have anything else on that on the algorithm? Because it is hard. And so I wanted to point out a simpler algorithm the CDC has. It's going to be hard if you're not with the Maine health practice. My worry is, will that be updated for you? We have been updating the algorithm constantly. And so the other option is to go to this CDC stoplight and really work with that. Because again, it reiterates those same issues, but using the algorithm sort of points out what the concerns are that we'd gone through. But again, it's just polyethylene glycol, polysorbate are these excipients we're worried about. So if you've had a severe allergic reaction, you're in that contraindication to vaccination where you shouldn't vaccinate without discussion with a referral to an allergist immunologist. So first dose reactions, anything other than a little local redness or itching at the site should probably be referred and discussed. But you do want to clarify that these were truly allergic reactions to the first dose. We're seeing a lot of tingling, redness, flushing. Those are not considered allergic reactions, obviously vasovagal things, and the CDC has a lot of clarification later on about that. Precautions to vaccinations, again, you just want to weigh risks versus benefits and put them into a 30-minute observation period. So far, again, from the standpoint of anaphylaxis, the treatment has been effective. There have been no problems with the patients. They've all recovered when they've had it. And I just want to stress again the importance of epinephrine. There are really no absolute contraindications. People often start with Benadryl, but I tell people Benadryl only fixes hives and an hour. Epinephrine saves lives. So early use of epinephrine, if you are dealing with an anaphylaxis episode that's clear cut with symptoms beyond those of just a local reaction, ought to be treated with epinephrine early. There are no contraindications. And I think the rest is going through. I think those are the major points. And so the problem we're seeing now, or what to do, as everybody probably is, with the first dose reactors. And so local allergists are now setting up to try to do skin testing for the polyethylene glycol and polysorbate. Again, we don't know how valuable that will be, and then how those patients will receive their second dose in a safe, observed setting are hurdles that we're trying to overcome right now. So, so I know that Allergy and Asthma Associates, Maine General hospital, Scott Dyer, are trying to set up testing. But again, we'll be wanting to be sure that appropriate patients only are getting there. And Mass General Hospital that did this study that I'll show next, Lisa, the slide following this, they're actually evaluating whether it is the polyethylene glycol. So they're doing a lot of skin testing on their population. And this is a conjoined study with Vanderbilt. And it's an excellent reference, though, for medical directors, people running clinics, because it has a list of all of the vaccines that contain polysorbate and their relative content. It has the polyethylene glycol. And so I've got that reference here. And then I think the next slide, I think, are just references. But I do want to point out the medication lookup for polysorbate and polyethylene glycol, the daily med one. If you don't, that list is incomplete in the Jackie thing for polyethylene glycol. So it's good to use the daily med lookup. Just go to the bottom to look up active and inactive ingredients. And the same thing for the vaccine lookup, the CDC guidelines there. And then I reference that Jackie in practice. Anything I've left out, Lisa? It's just a lot to review quickly.
That is a lot. And I apologize. I know I told you up front that you'd have control of the cursor, and then I didn't realize you wouldn't. I hope I followed along there with my glasses on.
You did great. For that spaghetti mess of the algorithm, but it's just, thank you.
So I suspect that we will have many questions about that, but we don't have too much else. Maybe if we just keep going with the slides and then we'll come back to the questions. Maybe Steve, a quick update on J&J,
Sure.
and then I'll run through just a few administrative sort of updates.
Great. The Johnson & Johnson vaccine, which we've all heard about, it's the one-shot vaccine, was presented to the FDA on the 4th of this month. They had said at that point in time that it was likely within 3 to 4 weeks that they would go through all of the data and have that probably ready for approval or not. That takes us actually to about Thursday or Friday of this week. My understanding is either Thursday or Friday, the FDA is going to be providing their decision. If they decide to support that, which most people think they will, that will then go to the ACIP. ACIP will provide guidelines and information to the CDC. The CDC will then approve it. And if everything goes along as we expect, we're likely to start seeing J&J vaccine next week. Now, every one of those steps could be a little longer, but that looks to be the timeline at this point in time. The advantages of J&J is it's a single dose. It doesn't have cold storage requirements. It is an effective vaccine. It appears to have reasonably good efficacy against variant strains as they've been tested, certainly both the UK and some reasonable activity against the South African. The important part to think about this is it's 100% efficacious in preventing hospitalization and death, and that's really what we're trying to do. We also obviously see really good efficacy against severe disease. The advantages of this is we'll be able to roll this out to large groups of people. Given the fact that the storage requirements, the single dose, you can start thinking about community-based clinics. You can take this in whatever sorts of into smaller settings and to make this available. And so again, hopefully we'll see this very soon. I think the next two slides are interesting in that I know they're a little small, but I'd refer you back to the MMWR from February 19th. It's the CDC provided their first experience in both the Pfizer and Moderna safety monitoring. This is not just the anaphylaxis. This was really looking at the overall VAERS reporting and safety. And basically the bottom line is there was no surprises, which is really good. Local and systemic reactions were common. We knew that. There were rare reports, as we've heard, of anaphylaxis, no unusual, unexpected reporting patterns detected. And if you look, basically, it just sort of shows that, yeah, almost everybody gets a sore arm. Some people get some aches and pains. Some people get a little fatigue, headache, and fever, and those are all relatively they don't last long, and they go away relatively quickly. The next slide is with the Moderna, same thing. Again, it's seeing the same thing. This is both in the MMWR from February 19th. And as I said, the good thing is, so nothing really unexpected came out of this, and this has now been given across 10 to 12, 15 million people or more. And we've had an opportunity to really get an incredible experience, because you remember the vaccine trials were 40,000 for the 40,000 for Pfizer and 30 for Moderna. So off to you, Lisa.
Great, thanks. Just a quick plug for our ongoing health equity series. We didn't hold this session last Tuesday because we held the monthly series on Wednesday mornings. We'll continue that. There are links here about logging in. We talked about vaccine equity, and we'll be continuing that discussion next time. Also, just a plug that we have tools to try to promote that. We now have both the Maine Care and a City of Portland Public Health info sheet that are both available, both of these in 10 languages. And the links are embedded in these little images. So when we share the slides, you could get to it that way. The state did put out several updates to vaccine providers in the last few weeks, as well as updating the notifiable conditions list to say that sites need to submit a certain number of specimens for genomic sequencing on the lookout for variants. State put out a full use policy, and then there's also an opportunity for community organizations, primary care, other sites to come together around community collaboratives to make proposals for high volume distribution. And then a reminder that we are encouraging strict adherence to the priority phases as outlined by the governor. And again, these links all get to more info. Folks might have heard on the vaccine call last Thursday, in addition to Walmart sites, Walgreens sites will start offering vaccine as well. Both are supposed to be limited to 70 and older for now. I've heard that the registration screen maybe has not been updated yet. That is the current phase. I believe we're over 300,000 vaccines now. The website's also been updated and clarified a bit. Again, we are still just in 70 and over. More to come on that soon. We have several signals that will likely be moving to 65 to 69 sometime soon. The sites are all listed. This is our info. A huge thanks again to Peggy Penoyer for joining, and let's go to questions. Any of my co-hosts haven't been able to tee up any of those.
Steve, this might be for you. When you check VAERS, you can see entries under COVID vaccines that show death. How are the entries vetted? Because of this public information, people are reading entries and they're afraid it's going to lead to vaccine hesitancy.
VAERS is a what I sort of call an agnostic database. Everything that the CDC is really asking that everything be submitted. They will then periodically look at those things that seem to have correlation. If there are deaths, they generally there's a review and an evaluation. That doesn't mean that if somebody dies, 2 days after having a vaccine, it's not going to be put in there. It will be. And so I think that it's a raw database, but the CDC then will actually go and look at all of the results. They've also got their, in this situation, we also have what's called V-Safe, which is those of you who have been vaccinated know you have the option of opting into an optional system with CDC where they actually check every single day for symptoms, and they're gathering that database too.
This is probably for Peggy. Are GI symptoms within 4 hours an indication of an allergic reaction?
And I think that in isolation probably isn't, but we're seeing, again, tingling, numbness, some other little things that really are not to be considered allergic, but a little inexplicable, in terms of what this vaccine is doing. And I think we will see some things come out, but none of these are concerning. Those patients should go ahead with their second dose without without any other precautions.
Another question is around seeing shortness of breath the day after dose 2. Have you heard of that as a side effect?
Again, just are these patients asthmatics are the questions to ask. But again, we're really looking at that 4-hour window. We're trying to keep patients from being excluded for their second dose. So I've worked hard to try to actually get everybody cleared. And so really you want to look at that first 4-hour window, and the others you just find out, did they get their asthma stirred up later for some reason by the vaccination. But I think that would not be considered allergic. I would not consider that patient a precaution to vaccination or a contraindication.
How much does family history matter? If they have a family history of allergy to PEG or one of the additives, does that matter versus individual history, especially if they've never been exposed?
Only family history only influences how allergic you can be, but it doesn't influence the type of allergy you have. So being allergic to polyethylene glycol in a family member doesn't make you more prone. It just makes you more prone to be allergic, as any family history does.
Are the next set of vaccines that are non-mRNA have the same PEG or same concerns around allergies?
So the next vaccines are all polysorbate. Stephen, correct me if I'm wrong, but the AstraZeneca, J&J, and I think the Novavax is under consideration, have polysorbate. And it's unclear still, as I mentioned, how much polysorbate really cross-reacts with PEG. Are we being overly cautious? Polysorbate allergy is very uncommon, but does occur, and it's in everything. So it's just a widely used additive.
Next question is about mammograms, and I'm not totally sure about the question, but do you currently advise, what's the current advice for mammograms post-COVID
Sure.
vaccine?
Sure. There's actually some guidance that has now been put out by one of the imaging societies. It's not really written about all that much, but the question or concern is that some people get an exuberant reaction from the vaccine and can get some axillary adenopathy. If that were seen de novo on a mammogram without some underlying reason for it, it could cause increased evaluation when in fact it's not necessary. So the recommendation is to get a mammogram prior to, or at least 4 to 6 weeks after the dosing, if possible.
Peggy, this might be for you. After my first shot, I felt a sudden warmth in the palm of my hand and it went away after a few minutes. Is that a common reaction?
And I think we're seeing it very commonly. It's inexplicable. I don't see it with my allergy shot patients. It's just, this is so we don't know what that is, but it's not allergic. It's not considered allergic at the Mass General Hospital in their study of patients, and they're going ahead and vaccinating with that history. And so I did try to clarify that flushing, tingling, numbness, at anything that localized redness, those are not a contraindication to a second vaccination.
And Steve, is there an information sheet for J&J vaccine available to hand out, or does that only happen after the EUA is done?
Generally, it's after the EUA, because the EUA gets approved by the FDA and by the ACIP. It comes out very rapidly, and typically what happens is the EUA itself gets published, but there's also information sheets for providers and for people getting vaccinated very soon thereafter. There's some general information around and expectations, but the data really hasn't been published yet on J&J, other than what we've heard in news reports and relatively shortened versions from J&J.
And are post-vaccine reactions more prevalent in the over 70 population? Are you seeing any differences in age with vaccine reactions?
As far as the overall side effect profile, it appears to be occurring more commonly in the younger age group rather than the older age group. That was seen from the trials. Seems to be. I don't know that I've seen a good breakdown of that yet.
Peggy, can you talk about the delayed hypersensitivity and local reaction a week post-vaccine? I know that's come up in the past, but are you continuing to see that? Has there been evidence of further reaction with the second dose with these people? So they saw it on the first dose, or are they seeing it on the second dose as well?
I'm not getting a good sense of numbers, but just polling my few patients that have reported this, and that I've been able to get second dose information, and it looks like maybe half do, half don't. They could switch arms if they're worried, but there's no reason not to go ahead, as everybody's been told on previous sessions. But those reactions can look impressive. But if they didn't start, if they were only local and are delayed like that, they should go ahead with their next dose on schedule and should avoid oral steroids. I keep saying that, but we don't want to treat those with oral steroids and blunt the response to the vaccine.
I jump in with a question, Amy. So back to steroids. So Peggy, I know we've talked about it on this before, and I hit you up for advice on my 90-year-old mother, but both in that circumstance, and then I've got another question today about intra-articular steroids, that some of the offices are starting to have a 2-week hold policy, and older adults who aren't aware of that come in or are told that they need to delay their shot. Any more official stance on this?
Steve, unless you're aware of anything, I think that if you look, morning cortisol levels are suppressed for about a week after a dose of intra-articular steroid, but it's pretty minimal. But I think out of caution, they should maybe consider waiting a week. But I think 2 weeks is a lot of time.
Or if somebody already
and
has a
limited
vaccine
guidance.
scheduled, like to cancel,
Yeah.
it seems like canceling it
It
is.
seems like it probably isn't necessary, but we have no guidance. Stephen, I don't know if you've
Right.
seen.
No,
anything.
I think that, as always, if you look at the guidance, it's going to be incredibly cautious overall. Realistically, it probably doesn't make that much difference. And if that's when you have to get it and it's only time available, delay it if possible, but go ahead and get the vaccine.
And then there's a similar one, use of NSAIDs before or after vaccination still being discouraged. You had commented on that previously.
Sure. Yeah, it still is being discouraged, but again, that's based off of theoretic data, no specific data for COVID vaccine. It's recommended not to use them as preventative. And if you have to use them afterwards, then you talk with your doctor, but it's okay. It's just not, we try not to use them routinely.
Question around temperature of Moderna. I don't know, Steve, if you know this. A memo from the CDC recently regarding transport of Moderna stated that shouldn't keep the vaccine defrosted refrigerated for longer than 12 hours. But federal CDC information sheet says it's stable at refrigerator temp for 30 days. Can you please explain?
I'm going to have to pass that one over to the immunization branch. We can probably ask that question, Lisa, to Tanya or someone, unless you know the answer.
Do not know the answer, and I will copy that and send it over to Tanya.
Another one is,
we'll get back to Karen. Yeah.
More around the use case for J&J. Would healthcare workers, especially in long-term care, be excluded from the J&J vaccine?
No, J&J is going to be widely distributed, and I think we're going to overall be considering most of these relatively equivalent vaccines. The goal will be to try to vaccinate as many people as possible, and this will allow us to get to that place sooner.
All right. Actually, I'll ask one more, Peggy, since we've got you here. The algorithm that you went through from Maine Health, and then you get the stoplight version, that obviously is great if they have somebody like you, but most sites don't have a you. So, how does that get translated? And I'm thinking Walgreens, Walmart, I mean, presumably they're just having the patient fill out that form. What's the practical application of that?
It's tough to say, and everybody's wrestling with this issue because, are some people blithely going on and vaccinating? And we're seeing that these vaccines are pretty safe, and that risk-benefit ratio is pretty high to exclude a patient. So I think if you've got the treatment for anaphylaxis available, it has been effective. There's no contraindication to epinephrine. We just encourage them to look for these worrisome signs in patients based on the algorithm. And I think the CDC algorithm points that out, and hopefully they're using the CDC check-in forms that we pointed out, the consent form, so that they're highlighting those patients. But they can also consult an allergist. So if they have questions, they can contact a local allergist.
All 4 of them in the state you pointed out right now.
Yeah.
Peggy is actually retired now.
Five.
5, okay. All right. Well, thank you for donating your time in your retirement. You and Dr. Sears are the worst examples of retirement I've ever seen, but we are really grateful that you took the time to set this up for us and join us today. We will be holding the session again on Friday at noon, as we do. And then next week, we may have more to say about J&J, we are hoping.
I hope so.
Yeah. All right. So thank you all. Thanks again, Peg, Steve, and everyone for joining. We'll see you next time.